Good evening, everybody, and thank you for joining this evening's webinar, which is sponsored by Nestlé Health Science, and it's on advancing the management of cow's milk protein allergy, human milk oligosaccharides, and immune development. I'm Charlotte Duncalf. I'm the Medical Affairs Allergy Dietitian for Nestlé Health Science, and we have two speakers for you today. We have Dr. Nitin Makwana and we have Professor Anna Novak-Bergstein as well. So what I'll do first of all, before I introduce them properly, I would just like to run a poll question for you. So if you would just like to answer it, would you recommend hypoallergenic formulas supplemented with 2-HMO for the dietary management of cow's milk allergy? If you want to say yes, no, or if you're undecided as well. If you'd just like to click that, I'll give you a few seconds to kind of click onto that. And while you're doing that, I would just like to introduce our first speaker. So our first speaker today is Dr. Nick Makwana. He's a consultant paediatrician. He specialises in paediatric allergy at the Department of Child Health in Stanwell and West Birmingham NHS Trust, where he leads the multidisciplinary paediatric allergy service, which sees around 3,000 patients a year. He also is the group director for Women and Child Health, and he also is the paediatric curriculum lead and senior clinical lecturer at the University of Birmingham. And today, Nick Makwana's talk is covering human milk oligosaccharides and their role in the early life immune development. Okay, we'll just see how many people have answered. Okay. So we can see it's a few of you still undecided. So we've got 64% said that yes, they would recommend hypoallergenic formulas supplemented with 2-HMO. We've got 7%, so only a few that say no, and then 28.6% are undecided. So let's see if we can change people's minds, and I shall pass you over to Dr. Nick Makwana.
Okay. Hi there, everybody. Thanks for the introduction, Charlotte, and thank you to Nestlé for asking me to talk today about the structure and function of human milk oligosaccharides, or the so-called HMO'S. Here's my declaration of interests. I've received honoraria from Nestlé for delivering educational sessions and sponsorship to attend educational conferences. So the outline of my session today is just to discuss the importance of the microbiome in health and disease, a reminder of what pre, pro and symbiotics are, what are HMOs and how are they different to other oligosaccharides, and then a little bit about the benefits of HMOs in human milk. So I think it's worthwhile just reflecting where we are with the management of food allergies at the moment. If we look at the last few decades, in the past, if a child had a food allergy, all we could do was tell them to avoid the food and wait for them to grow out of it. If you're a child with cow's milk protein allergy and your mother was unable to or could not breastfeed, then you gave an EHF or an amino acid formula and sat it out. Where we are at the moment is in the present, which is tolerance development. So we're trying to modulate the immune system, and certainly this has proven to have benefits. So, for example, for children who are milk and egg allergic, we do ask them to have baked milk and baked egg in their diet. And so there's twofold benefits of this. Firstly, it improves quality of life because the child has a much better expanded diet. And secondly, there's some evidence that you grow out of your allergy quicker if you can tolerate baked milk or egg in your diet itself. Also, a number of milks now contain specific oligosaccharides, which have shown to have benefits on the overall immune system. Obviously, what we're hoping in the future is that there'll be even more potential for specific oral tolerance induction to foods, and taking it even further, changing the gut microbiomes and microbiota of infants who may be at risk of allergy or already have an allergy to prevent future allergies or atopic disease. I think we're quite a way off still from that, and we're all going to be in jobs for quite a while still. So if we think about the microbiome, if you look on the left-hand side here, you can see the microbiome interacting with the host defenses and immune system. And what this does is protect against pathogen colonization. So having a healthy microbiome maintains mucosal integrity, and the interactions lead to the development of a normal immune response. Unfortunately, certain factors such as toxins, pathogens, diet and drugs, including antibiotics, can change that microbiome completely and lead to what we call a dysbiosis. This means there's a change in barrier function and therefore a difference in interactions that changes your immune development and can lead to disorders, including allergy. That first colonization is critical in this, and actually those early host microbe communications are critical at shaping what your future immune system will look like. So it's really important getting that microbiome right early on. So if we think about what a normal microbiome looks like, if we look at this pictogram, you can see early on in life, it is predominated by bifidobacteria, which is that big blue circle. And as you start weaning at 4 to 6 months, you introduce different species and Clostridia start becoming apparent. You can see the balance changes there. Then over the next sort of few years, what happens is there's a greater bacterial diversity. And eventually, by around 3 years old, you end up with your adult microbiome and what it will look like. If we take a moment here just to remind ourselves what pre, pro, and symbiotics are, remember that a prebiotic is a substrate that selectively is utilized by a microorganism conferring a health benefit. A probiotic is a live microorganism which, when administered, confers a health benefit on the host. And a symbiotic is a combination of the two that have a synergistic effect when paired together. So breast milk is a rich source of pre and probiotics. So human milk contains lactobacillus and bifidobacteria to help seed the gut. And breastfed infants develop an intestinal flora dominated by bifidobacteria. And this is very different to formula-fed infants, which have a very different microbiome, including more pathogenic bacteria and early colonization of clostridial species. Human milk oligosaccharides are an important component in human milk. And part of this is due to the prebiotic effect, which we'll talk about. But in addition, they have a number of other benefits, which again, we'll touch on in a minute. If we think about the gut microbiome in allergy, it is very different and there is a dysbiosis there. So as we've already highlighted, we've got early colonization with bifidobacteria. But if we look at infants with IgE-mediated allergy, typically there's much lower levels of bifidobacteria. And children with a non-IgE-mediated allergy have a dysbiosis driven by Bacteroides. So again, in order to manipulate that microbiome to get it to a more healthy one, you can see there is probably a potential role of pro and prebiotics to correct this dysbiosis. Again, it's important to remember that the gold standard nutrition for cow's milk protein allergy is breast milk, and all current guidelines support breast milk as a first-line choice for the prevention and dietary management of allergy. So what we need to do is support mother to breastfeed, support mother to avoid cow's milk protein if appropriate, and that's usually quite rare that we need to do that, and importantly to ensure maternal calcium and vitamin D intake. Now in some cases the mother may be unable to or chooses not to breastfeed, and in these children we need to choose a hypoallergenic formula, and then we need to consider which one will be most appropriate. So what are HMOs? So if we look at the components of breast milk, we know that 90% of breast milk is water, and then there's a number of macro and micronutrients. So if you look at the solid components of breast milk, we can see that lactose is a carbohydrate that is a majority of it, and then lipids. And HMOs are actually the third largest component of breast milk at 5 to 15 grams per litre. If we compare this with cow's milk, this has a 100 to 1,000-fold less HMOs, and formula milks contain no HMOs unless they're specifically added. Those HMOs, as you can see on the far right, are further broken down according to their structural nature. So we'll talk about what that is next. So HMOs, so oligosaccharide literally means few sugars. So they're composed of 3 to 10 monosaccharide units, and these are the 5 monosaccharide units that link together to form HMOs. So you've got glucose and galactose, which link together to form lactose, N-acetylglucosamine, fucose, and sialic acid. All of the HMOs have a lactose core, and then different structures depend on which of those monosaccharides are connected to that lactose core. And the different structures will determine their function. So if we look here, for example, you can see that in the second box there, the lactose core is highlighted, and then you have branch structures or linear structures made up of those various monosaccharide units. Those are all neutral in nature, and one of the important ones there is LNNT, which is highlighted in the center. If you add a fucose molecule, you turn this into a fucosylated HMO. So that's the red triangle. And an important fucosylated HMO is 2FL, as noted there. Again, those two types of HMOs are neutral in nature. If you add a sialic acid component, then you change it into an acidic HMO, and those are demonstrated in that final box at the bottom. So you can see there's quite a structural diversity in the HMOs there. So if you think of HMOs as Lego blocks, all those Lego blocks are the different monosaccharide units. How you put them together will determine their structure and function. And I'm sure we'll all agree that the structure and function of Donald Trump and Joe Biden are both very different indeed. So again, this just represents those HMOs we've talked about, and you can see a majority of HMOs are fucosylated. A smaller proportion are non-fucosylated and sialated. Now, there's about 200 HMOs that have been described, of which 20 are sort of relevant in breast milk. And again, I've shown you the two that we're going to particularly focus on there, which is 2FL and LNNT. One is a fucosylated one, which is a 2FL, and one is non-fucosylated, which is the LNNT. So HMOs are generally regarded as a non-digestible carbohydrate because they pass through the gut as there's no enzyme to actually digest them. So 98 to 99% pass through and are excreted out. We know that a small amount are absorbed systemically because we found them in the urine of infants. So they reach a systemic circulation, and we're only really beginning to understand what they do there. There's a number of factors that influence HMOs in human milk. The three main ones are lactation stage. So we know there's more HMOs in colostrum compared to sort of milk that's produced later. Maternal genetics are particularly important. So a majority of mothers, so that's 80% of mothers, have what we call the FUT2 gene. Now this gene makes them a secretor of an abundance of 2FL. So these have a secretor status. 20% do not have that secretor status and produce different HMOs, but not an abundance of 2FL. And the duration of pregnancy is also important. So we know that preterm milk has much less HMO than term milk. There's a number of other external factors that are noted there, which we don't have time to go into today, but have a much less effect compared to the three we've just talked about. So you've probably heard of GOS and FOS, galactose oligosaccharide and fructose oligosaccharide. How are HMOs different? So if we look here, you can see, and we've already discussed, HMOs are found abundantly in breast milk. GOS is found in very minimal amounts, really, and FOS is not found at all because FOS is a plant-based oligosaccharide and usually is introduced when weaning begins. Also, you can see the structures are much simpler of GOS and FOS compared to HMOs. Whereas GOS and FOS are predominantly, well, they are prebiotics, HMOs have a number of other functions beyond their prebiotic capabilities, which we will talk about next. So here are the sort of four main sort of functions when we've looked at in vitro studies of what HMOs will do. So they act as antivirals and antimicrobials, they act as prebiotics, they modulate the gut barrier function, and they have a direct effect on the immune function of the infant. So let's take each of these in turn. So first of all, let's look at the supporting of beneficial bacteria. So they lead to a bifidobacteria-dominated gut microbiome, which is, remember, what we really want in these infants. And that leads to a competitive exclusion of potentially pathogenic bacteria. They're also able to sort of with bifidobacteria enhance the metabolic activity related to production of short-chain fatty acids. And we know that short-chain fatty acids improve intestinal barrier function, reduce the pH, and are anti-inflammatory in nature. So all good things to have going on in your gut. Also, if you remember, there's so the secretor mothers establish early bifidobacterial microbiome as shown in this graph. So you can see the secretor mothers in grey have much higher levels of bifidobacteria, and also these are established much earlier compared to non-secretor mothers, where there is a higher preponderance of those potentially pathogenic bacteria. And infants fed with a formula containing HMOs have a similar microbiome to breastfed infants, which is again what we're trying to aim for if we have to give a hypoallergenic formula. So secondly, they enhance gut barrier function. So they stimulate gastrointestinal tract maturation, and they promote enterocyte differentiation, and therefore enhance the barrier function. They also change the gene expression of the intestinal cell, which reduces the ability of the pathogen to actually adhere to it and therefore cause infection. So they also directly modulate the gene expression within intestinal cells. Thirdly, they are antimicrobial and antiviral. So pathogens bind to lectins, which are a type of glycan, colonize a host and then cause disease. HMO look very similar to glycans, and therefore the pathogen will attach to the HMO. As we've seen already, the HMO then gets excreted out and the pathogen then leaves the body without causing disease. So they're really part of the innate immune protective response. They also have some direct bacteriostatic and bactericidal properties, which we can talk about in a bit. Finally, they have direct immunomodulatory effects. So we know that cytokines are produced by the body by T cells, particularly T helper cells, and these are CD4 expressing. So there's two types of T helper cell responses. There's a pro-inflammatory response, or Th1, and this is driven by the cytokine interferon gamma. There's also the Th2 response, which is an anti-inflammatory response. This is a type of response that leads you into atopic disease and is sort of exhibited by IL-4, IL-5, and IL-13. And in allergy, there's a Th2-weighted imbalance. What the HMOs have been shown to do is modulate dendritic cells and intestinal epithelial cells to work on the lymphocytes to balance that Th1 and Th2 response, which is what we're really aiming for in the immune development. And this can be shown here. So these are infants who are being given a formula containing 2FL. So you can see the control formula is a formula without HMOs. You can see the breastfed cytokine profile second there, and then the profiles in infants who've had a formula milk with HMOs. And you can see at the baseline, the cytokine profile is much more similar to a breastfed infant. And when cells are stimulated by a respiratory syncytial virus, the response again is much more similar to a breastfed infant rather than the control formula infant. So again, showing that there just seems to be a translation of that into cellular responses. So what our basic models show is that the 2FL particularly, also LNT, prevents group B streptococcus growth by inhibiting cell wall production. And it also prevents Streptococcus pneumoniae attaching itself to airway epithelium. 2FL prevents adhesion by Campylobacter jejuni to the intestinal wall and also dampens inflammation caused by pathogenic E. coli. 2FL has been shown to reduce RSV viral load, and LNT has been shown to reduce influenza viral load in airway epithelium. So again, there is some direct effects on the microorganisms that are pathogenic. So this is already quite exciting stuff. But how does that translate to patients? That's all well and good to hear. What does that mean? Well, there's an increasing body of evidence now showing that there is an impact on morbidity in these infants, as well as infection due to diarrhea and upper respiratory tract as well. The problem with a lot of these studies at the moment, I call it emerging data because these were often a secondary outcome to these studies. So here are a number of studies that I've sort of put up there looking at HMO impact. And you can see in blue there are a number of observational studies. In green there are a few case control studies. and in red, some randomized controlled trials. Now, those randomized controlled trials were mainly there looking at the growth impact of the formula rather than the secondary outcomes, which were then analysed at a later stage. But what they seem to show is that there's a reduced mortality in NEC in neonates. In those with HMOs, there's a reduced incidence of diarrhea, as well as respiratory tract infections. In addition, there's a reduced use of medication, including antipyretics and antibiotics. We can look at that in a bit more detail in one of these studies here. So in an infant-fed formula supplemented with HMO, there's a reduced risk of infectious illnesses and related medication. So if you look on the right side of the graph here, you can see there's a reduced incidence of bronchitis. Now, in this case, bronchitis really lumped together VAR-induced wheeze and RSV bronchiolitis. And again, you have to bear in mind that this was parent-reported rather than physician-diagnosed. Also, you can see there's a significant reduction in antibiotic use. So again, although these are sort of not powered to look at this, the direction of travel seems to suggest what we would expect it to based on what we know about HMO structure and function. Now, does this translate to a change in the microbiome? Could that be what's driving this? So if we look a bit more detail at the fecal colony types, so all you really need to see is that breastfed infants here on the left have a fecal colony type B. Control, so this is a formula without HMOs, have fecal colony type C. And in the middle, you can see the test formula, which has a sort of halfway house between the two. On the right-hand side are some Kaplan-Meier plots showing the time to first antibiotic use, which we just sort of looked at in the previous slide. And you can see if you've got a fecal community type B, i.e. a breastfed type microbiome, there's a greater delay into that first use of antibiotic and a much less or a reduced use of antibiotic. And that's really important because, as I've already said, antibiotics are one of those drugs that will cause dysbiosis themselves. So it does seem that some of the effect may well be related to the microbiome itself. So again, this seems to follow what we would expect it to, although we will need bigger powered studies to define this in more detail. So really, to finish off, I hope you sort of understand now that HMOs are the third largest solid component in human breast milk. They are quite complex structures consisting of 3 to 10 oligosaccharides, and the structure of HMOs are quite unique and determine function. You can see that 2FL and LNNT have similar but also very different functions and very different impacts on microorganisms. 2FL and LNNT are one of the most abundant HMOs in breast milk, and they've been shown to have benefits on immune and gut function. And finally, what we've looked at is some emerging data which shows that these immune effects may well translate to reduced risk of infections and reduced antibiotic use in infants, and thereby confer a beneficial effect in the long term. Thank you very much for listening.
Thank you, Nick, for that excellent presentation. If you have any questions, please can you message in and ask away, and we will make sure that we can cover as many questions as we can at the live Q&A at the end. So feel free to keep submitting questions as we go through, and I think we can all thank Dr. Nick McWarner for a brilliant presentation. We are now on to our second speaker and second talk today, which is we are joined by the lovely Dr. Anna Novak-Bergstein. She's the Professor of Pediatrics at New York University Grossman School of Medicine, and she's also the Director of the Pediatric Allergy Program. And today she will be covering the new data on the benefits of 2-HMO in the management of cow's milk protein allergy. Okay, thank you.
Thank you, Charlotte, for your kind introduction, and thank you for having me. I really enjoyed Nick's presentation. This will be complementary, and some of the concept will be reinforced. Here are my disclosures. I am receiving an honorarium for this presentation. I was also a recipient of a research grant and a principal investigator for the clinical study that established hypoallergenicity of whey-based extensively hydrolyzed formulas with 2-HMOs. And my objective for today is to describe the new evidence in support of adding human milk oligosaccharides as an important component of the hypoallergenic whey extensively hydrolyzed formula for the management of cow's milk protein allergy. So we know that breast is the best, and there are many reasons why breastfeeding is a preferable mode of feeding for infants, but one of them is the fact that human milk is a very immunologically active fluid. And it has the capacity to influence immune-related outcomes in infancy and early childhood, but also which can have long-lasting consequences even into adulthood. As Nick mentioned, human milk contains hundreds of different ingredients. These include proteins such as cytokines, for instance, TGF-beta, inflammatory mediators, signaling molecules, soluble receptors, polyunsaturated fatty acids, human milk oligosaccharides, which are the third most common solid ingredient, and a complex microbiome. Since So breast milk is really an ideal symbiotic because it contains both pre and probiotics. And more than 200 human milk oligosaccharides were detected in human milk up to date. And as Nick explained to you, they consist of short and long chain structures with the predominance of the short chain structures in a 9:1 ratio. I want to highlight one particular study that identified that. So Nick discussed the studies looking at the secretor status of the breastfeeding mothers. Another study from Finnish cohort of cow's milk allergic infants. And it was noted that there's a different composition in HMO'S in the breast milk of mothers who had infants with cow's milk allergy compared to the non-allergic healthy infants, suggesting that indeed the composition and probably the amount of HMO in breast milk plays an important role in predisposing infants to cow's milk allergy. This interesting study that I want to discuss also showed that microbial communities in the gut are incredibly important in early life. And in fact, as early as at birth or within the first few days after birth, the composition of the gut microbiota can predict the atopic status of the infant at 2 years of life. So this is data derived from a cohort study in the US. Where infants born to with risk factors for development of atopy, such as having one or two parents or at least one sibling with atopic disease, were evaluated and their microbiota was tested. And you can see that the composition of based on the composition of microbiota, they were clustered into 3 groups. And the group number 3 had the lowest abundance of so-called healthy species, predominantly Bifidobacteria and Lactobacilli. And on the y-axis, you can see the primary readout was the sum of specific IgE at 2 years of age. And infants, newborns who were in this group 3 with the least number of beneficial microbiota and healthy species had the highest percentage of allergic sensitization at the age 2 years. So this particular study looked at asthma development, but it's very likely that it also extends to other allergic diseases. So neonatal gut microbiota does influence susceptibility to childhood allergic conditions via alteration in the gut microenvironment. So microbiome drives immune maturation and immunoregulation. It can modulate immune responses. In contrast, dysbiosis, so alterations either in the level or diversity of bacteria, does affect immune system development. I should mention or remind you, some older studies show that mice that were born in germ-free facilities fail to develop oral tolerance. So this interaction between the immune system in the gut and the microbiota is really of critical importance. During infancy, Bifidobacterium and Lactobacillus dominate the gut, and their metabolites, in particular short-chain fatty acids, help immune maturation. They do appear to skew immune responses toward immunoregulation. That is to balance the Th1 and Th2 responses, and newborns and young infants have a natural imbalance in the favor of Th2 responses, and there is this rebalancing of the in favor of Th1 that occurs over the first few years of life. Of all of the studies, it has been determined that the key factor that influences gut microbiome diversity in infants is the mode of feeding. Breastfeeding increases colonization of lactobacilli in the bacteria compared to formula feeding. So you can see just the graphic representation of interaction between the gut microbiota, their metabolites, with the immune system, as well as the positive effect on the intestinal barrier permeability or integrity. There are many immunomodulatory factors in breast milk. I want to focus on particularly lactose and HMO, but we cannot forget that there's also secretory immunoglobulin A, lactoferrin, and antimicrobial peptides, as well as cytokines. So these act as barriers in the gastrointestinal tract or indirectly provide immune support. So for instance, lactose upregulates defenses, especially against gastrointestinal infections, through antimicrobial peptides. And this function is enhanced in the presence of butyrate. Whereas human milk oligosaccharides act as major substrates for bifidobacterium and increase levels of short-chain fatty acids, in particular butyrate. I just want to show you the study that compared the fecal microbiota of infants fed with cow's milk protein allergy who were fed with formula with and without lactose, and how they compared to the healthy breastfed infants, which are shown as blue bars in the figure on the left. Infants with cow's milk protein allergy fed with formula with lactose are shown in orange bars, and then infants who are fed with allergy who were fed formula without lactose are shown as purple bars. So you can see in the top part of the graph that fecal microbiota of the infants with cow's milk protein allergy fed with formula with lactose was more aligned with was closer in terms of the amount of number of bifidobacterium and lactobacillus species, closer to breastfed infants than to infants with cow's milk allergy fed formula without lactose. At the same time, there was an also effect on pathogenic bacteria such as Clostridium and Bacteroides, decreased, were lowest in healthy infants fed breast milk, but were significantly decreased in infants with cow's milk allergy who are fed formula without fatty acid. So I see a question here. I'm not sure whether I should be seeing this. Let's move to another slide discussing the anti-inflammatory role of butyrate and disease protection. So I mentioned before that human milk oligosaccharides serve as substrates for the gut microbiota. They are non-digestible, so they pass through the intestinal tract until they reach colon, and then they're metabolized, fermented by gut microbacteria. Short-chain fatty acids are organic acids, and butyrate is the primary energy source for intestinal epithelial cells, and it's known for its health-promoting properties. And Nick discussed some of those effects. And in particular, butyrate has been the most extensively studied. It does interact with the intestinal cells, improving their metabolism and reduces their oxidative stress, and also improves gut barrier function. It does also improves mucin release, transabsorption of electrolytes and water. In general, has an anti-inflammatory effect. It's possible that the production of toxic metabolites with less favorable bacterial species and a lower availability of short-chain fatty acids are involved in the pathogenesis of disease, including allergic diseases. So that makes the microbiome to be considered as a therapeutic target for treating inflammatory diseases, particularly allergy. And in addition to butyrate, there's, of course, acetate and propionate. And as Nick mentioned before, the butyrate has been shown to interact also with the cells of the immune system, such as dendritic cells or Tregs. And in fact, epidemiologic studies from Pasteur and Ephraim Berg cohort showed a correlation between the levels of fecal butyrate levels at 1 year of age and the development of allergic sensitization at 6 years of age. So purple bars represent those infants with the low fecal butyrate levels. Orange bars represent those with the high fecal butyrate levels at 1 year of age. And you can appreciate that for both food allergen as well as inhalant allergens, those with low fecal butyrate levels at 1 year of age developed higher percentage of allergic sensitization at 6 years of age, supporting the importance of modulating the environment in the gut to promote development of short-chain fatty acids. So you've got this, you received this great insight, great background on why we think that supplementing formulas with human milk oligosaccharides is important, makes sense. And as Nick mentioned before, there are two human oligosaccharides, true-fucosyl lactose and lacto-N neotetrarose, that has been identified as the most important HMO'S for inclusion in the infant formula, and they are responsible for the large proportion of the human oligosaccharides in breast milk. So I want to share with you the results of a clinical trial that we've conducted. It was called the Ivory study, where we tested a whey-based extensively hydrolyzed formula with two HMO'S in patients with IG-mediated cow's milk protein allergy. It was a multi-center trial that involved 11 sites. We've included infants and young children up to the age of 4 years who were not being breastfed, and they had a physician-diagnosed IG-mediated cow's milk protein allergy, either based on the history of the reaction and evidence of IG sensitization by serologic measurement or positive skin prick test, or highly predictive milk-specific serum IgE levels or skin prick test wheels that gave us high probability of that patient being truly clinically milk allergic. So the study formulas were extensively hydrolyzed whey-based formulas that were the test formula was modified Althera, which is manufactured by Nestle, and it was enriched with the two HMO'S, and the concentration that was consistent with the amounts seen in breast milk. And compared to the original Althera, it has a reduced content of extensively hydrolyzed whey protein to 2.2 gram per 100 kilocalories based on the directions from the EU for obesity mitigation. A control formula was commercially available, extensively hydrolyzed formula that has been previously tested and established as a hypoallergenic formula, and it contained a little bit more whey proteins, 2.5 gram per 100 kilocalories, and no HMO'S. And otherwise, these two formulas were identical. So the study design was quite simple. Randomized infants underwent blinded food challenges in a random session. With the first, they were randomly assigned to either receive first the test formula or control formula. All participants completed both tests, or were supposed to complete both tests. There are several subjects that were excluded from analysis because they did not ingest a sufficient amount of formula. And there are some other reasons for discontinuation. So you can appreciate that in the intention to treat analysis, there are 67 participants. In the modified intention to treat, 64. After exclusion of the 3 subjects after the first round of challenges, and then additional 3 subjects were excluded for various reasons. So for protocol analysis, there are altogether 61 subjects. And here you can see the results of the modified intention to treat analysis with 64 subjects, or per protocol analysis with the 61 subjects. And both types of analysis concluded that more than 90% of subjects tolerated the new whey-based extensively hydrolyzed formula with 2 HMOs, confirming safety and efficacy. And I should probably backtrack a little bit just to say that whenever you introduce a new formula and you want to have the designation of a hypoallergenic formula, it is important to prove that the new ingredients do not change the allergenicity of the original product. So this was the rationale for performing those studies, to reconfirm the hypoallergenicity of that product. And these results indicate that this new formula met the hypoallergenicity criteria as established by American Academy of Pediatrics Committee on Nutrition more than a decade ago, and those criteria are being used widely. So let's talk about the breast milk, human milk oligosaccharides, and infection risk, because as Nick mentioned before, this was one of the observations that was made in previous studies. So you probably know, it's just important to remind you that infants who are exclusively breastfed for at least 4 to 6 months have a lower incidence of upper respiratory tract infections, lower respiratory tract infections, and gastrointestinal infections compared to fully formula-fed infants. The reduced rate of infection in breastfed infants, it is attributed to the immunomodulating and microbiome modifying effects of human milk oligosaccharides. Beneficial effects of HMOs on respiratory and GI infections include reduction of viral load, such as RSV, increased production of short-chain fatty acids, as well as acting as decoys for bacterial pathogens, so leading to reduced mucosal adhesion and invasion. The infants study that Nick presented, those infants who were fed not just a standard cow's milk-based formula supplemented with 2FL and LNNT, were observed to have significantly fewer lower respiratory tract infections and require significantly fewer courses of antibiotics in the first year of life. So this was a very exciting observation. And I want to show you some of the results from the infants with cow's milk protein allergy. But before I do it, I will share more data from that original study, which was a prospective randomized controlled multi-center interventional clinical trial of 2 parallel formula-fed groups, which was done in Italy and Belgium. This study enrolled healthy full-term non-breastfed infants, and those were assigned randomly to control formula, which is a whey predominant with long-chain PUFAs, and to test formula, which was a control formula with 2 HMOs, 2FL and LNNT. And there was also a breastfed group that was observational group. And what was observed was that the main sort of outcome, the primary outcome of the study was growth. That was the main reason why the study was conducted. And it showed that the addition of HMOs does not is well tolerated and supports normal growth in those infants. But also as a secondary endpoint, there was an observation that infants who were fed a regular infant formula with HMOs had significantly fewer reported infections, bronchitis, lower respiratory tract infections, antibiotics, and antipyretics use. And not sure if I followed this topic, and recently there was a publication in the Mayo Clinic archives or proceedings of Mayo Clinic in Rochester, Minnesota, from the Rochester Epidemiology Project, which showed that infants who were given one or more courses of antibiotics in the first 3 years of life had higher rates of atopic diseases later in life. This included asthma, as well as atopic dermatitis and food allergy. So the effect of reducing the need to use antibiotics appears to be particularly important clinically. So our study was just a very short-term study. We had a week of home feeding with this new test formula, which also showed it was very well tolerated and there were no adverse events. But the second clinical trial, which is called Cinnamon study, under the direction of Vanden Plas, really followed those patients for a longer period of time. This was a controlled, double-blind, randomized, multi-center interventional clinical trial of 2 formula-fed groups designed to show non-inferiority in growth, which is the primary outcome, as well as secondary outcome, infection rate, related drug use, and fecal microbiome of infants with cow's milk protein allergy fed formula with or without HMO'S for 4 months. So the inclusion criteria were full term between ages 0 to 6 months with the diagnosis of cow's milk protein allergy, not being breastfed. And the study population was a mix of IgE as well as non-IgE mediated food allergy. Infants had to have at least 2 symptoms from the following, such as persistent crying, regurgitation, liquid stools, constipation, atopic dermatitis, urticaria, or persistent respiratory symptoms. However, if diagnosis was based on either positive specific IgE in the serologic testing or skin prick test or patch test or food challenge, only 1 symptom from the above needed to be present. So here's the design. Baseline at baseline V0, patients were randomized 1-to-1 to either receive test formula or control formula for 4 months. And then after 4 months, the primary endpoint was evaluated as weight gain in the non-inferiority design. And then after 12 months, there were secondary endpoints that were evaluated, such as Z-scores for weight, height, head circumference, clinical tolerance, as well as rates of adverse events, including infections and medication use. Study formulas, I'm not going to belabor the point. They were the same. This is the same formulas that we compared in our hypoallergenicity study. And here are the results. So 100 was a larger study with 194 participants, 51% were male, with the mean age at enrollment 3.2 months with a range of 0.1 to 6.1 months. So older infants that compare with the healthy infant study. There was primary endpoint showed that there was no difference in the weight gain per day in the study from the baseline to 4 months into the study. And also then we will be looking at the secondary outcome. So this is the primary endpoint of the growth. You can see that infants fed formula with HMO'S, which are shown in red, are not significantly different from infants fed with the conventional formula without HMO'S, so meeting the criteria of non-inferiority regarding growth. And I'm just showing you weight, mean body weight, but similar graphs have been observed for length as well as a head circumference. And in the secondary endpoint analysis, there was observed a reduction in the frequency of infective episodes. So this is the graph shows relative risk reduction. And you can see, again, 2 different ways of analysis, with the full analysis set shown in the dark blue bars and per protocol analysis set shown in the blue bars, in the light blue bars. And you can see that particularly regarding lower respiratory tract infections, upper respiratory tract infections, and otitis media, as well as gastrointestinal infections, acute diarrhea, there was a relative risk reduction regarding each of those. Now, risk reduction regarding viral infections. That's another way of looking at those risk reduction as odds ratios. Only one that was statistically significant was reduction in otitis media, shown in the protocol analysis. Every other parameter has a confidence interval that crosses 1, which means that they didn't reach statistical significance. But please keep in mind that the study wasn't powered to address those secondary endpoints. This was more of a sort of convenience analysis. But even with that limitation, there was a reduction in the upper respiratory tract infections, and there was also reduction in lower respiratory tract infections, but it wasn't statistically significant. We're talking here about the incidence rate of respiratory tract infections per month of study formula exposure. And this is including full analysis set. And you can see that the reduction in upper respiratory tract infection was indeed statistically significant. And again, it's just a different way of showing this relative risk reduction in the study. So I'm just going to skip those slides in the interest of time. And I want to show you what Nick has already shown, that there's a difference in those in the fecal microbiota in the between infants who are fed with the formula with HMOs versus those who are not fed formula with HMOs. And it's interesting that in the cinnamon study, there was a significant difference at 12 months, at V6, at 12 months after being exposed to the study from the study formula initiation. That there was a lower alpha diversity in infants who were receiving formula with HMO, 2FL and LNNT, compared to the infants fed with a formula without HMO. And there are two different ways of looking at this. This is richness and Shannon index, which is very technical, but just pay attention that both measures were significantly lower at 12 months, so at V6, in those box plots that are blue in color, which represent infants fed with the formula with HMOs. And it turns out that diversity, it really depends what kind of diversity we're talking about. And it turns out that it's better that the healthy breastfed infants have actually lower alpha diversity, which means that they have more sort of persistent phenotype from the early life, which has predominance of bifidobacteria and lactobacilli. And this is another way of looking at those very interesting data that has been reported and presented at FAM. And on the left, you can see the V0, so the earliest study visit, where there are majority of the patients have sort of fecal microbiota of early type, and then with each subsequent visit, there is decrease in the percentage of those with the early type to more blue, more purple, and red and yellow represent really late type microbiota, which is more typical of adults, of adult gut microbiota. And at the visit 6, so 12 months, you can see that those fed with the HMO formula have a higher percentage of their early type, so blue and purple, so cluster 2 and 3, compared to the clusters 4 and 5 in comparison to the control formula fed infants. On the right, you can see sort of the predominance of different bacterial species in different clusters. So for instance, in the cluster 1, cluster 2, there's mostly predominance of actinobacteria, which include bifidobacteria, as well as Firmicutes. So I think the key messages from my presentation is that human milk oligosaccharides provide the substrate for the developing gut microbiome of young infants, that human milk oligosaccharide composition of of human breast milk influences development of cow's milk protein allergy. Our short study, Ivory study, was the first clinical trial of whey extensively hydrolyzed formula containing 2FL and FLNT. The formula was very well tolerated by more than 90% of infants and children with IgE-mediated cow's milk protein allergy, therefore meeting the AAP criteria for hypoallergenicity. In the cinnamon study, which was a more long-term study where formula was fed for 4 months, it was demonstrated that this hypoallergenic formula with 2FL and LNNT supports normal growth in infants with cow's milk protein allergy comparable to a formula without HMOs. And furthermore, and probably even more clinically relevant, was the observation that infants fed formula with HMO had significant reduction in the frequency of upper respiratory tract infections per month of study formula exposure compared to infants who are not being fed with formula with HMO, as well as reduction in otitis media, which is statistically significant. And that these reductions in the frequency of infections observed in cow's milk protein allergy were consistent with reduced respiratory infections among non-allergic healthy infants who were fed regular infant formula with HMO, who were, I should mention, were also enrolled in and were started being fed with this formula at much younger age. And as Nick mentioned, the effect of the HMOs is most important in in very young infants right after birth, because that's where this is their major source of nutrition. So thank you very much for your attention, and I'm happy to take any questions.
Thank you, Dr. Anna Novak, for your brilliant presentation again. It was really good, really clear. I was just going to quickly ask the poll question again, just to see if everyone could answer. So I'll just push that through. So would, if we just ask it again, would anyone recommend hypoallergenic formulas supplemented with 2-HMO for the dietary management of cow's milk allergy? I'll just give you about 30 seconds to answer that. And then what I will do is I will go on to the live Q&A. Again, thank you very much for a brilliant, really good presentation. We have a few quick questions that have come through already. And actually, I think most of them, feel free to jump in, Nick, as well. But I'm not, I think they're probably both open to both of you. So we just put the poll question. Oh, fantastic. So you convinced everyone. So 100% of people will recommend hypoallergenic formulas supplemented with 2-HMO for the dietary management of cow's milk allergy. So if I just go onto the live Q&A, and we should be able to see and hear Nick as well if you come off mute as well. So if I go onto one of the first questions, so if HMOs were important for infants with cow's milk allergy, then why has it taken so long to add HMOs to hypoallergenic formulas?
Shall I answer that and give Anna a break from her long talk? So yeah. I think HMOs have been known about for a long time, since the 1900s, in fact. So they've been around for a long time, but there's been no way of producing them in a mass form industrially. So that's only recently being able to be done. So that's why it's only recently been that the HMOs have been able to be added to formulas, because we just had no way of producing them before that, even though they were known about for a long time prior to that.
Great, thank you. That's good. And do you see any other HMO blends inferring any other benefits in the future?
Difficult one. I don't know if Anna knows about that one. Anna, is that something you are aware of?
No, I think that, no, I don't, but I think that, the observational studies are ongoing. The infants were enrolled in the cinnamon study will be follow up, prospectively and to monitor for the outcomes in the study. I think that, really, it would be wonderful. This data is very compelling, and I'm so happy we've convinced you that, using formula with HMOs is a good thing. But it would be wonderful to have really good data, good evidence, regarding the infections, regarding the allergic outcomes or other health outcomes later in life, because that's really what matters. This is exciting preliminary data, but it would be wonderful to have just a definitive evidence. Having said that, I think that the risk of adding HMOs is minimal, right? It's a substrate. It's something that is being metabolized in the gut. It can only help. There's no obvious, disadvantage to it. And I know what I wanted to say. I wanted to say that the earlier, the better, right? Like you say that breast milk, right, is mostly packed with all of those nutrients early in life. And then, once you start introducing solids, it's still important. It's even important when you're 50 or, 60, what is your diet and what is sort of the, what probiotics and prebiotics are you taking? But it's particularly important in early life. And I feel like maybe 3 months is already late. If you can see that it's a microbiota is different at birth, like if we're waiting to intervene until they are 3 months or 6 months, it's it may be too late to see significant differences. But nevertheless, the observations are very exciting.
And I've just got a question. A lady asked, in the study you presented, at which age was the skin prick test done? It was kind of halfway through, so I think it was earlier than the cinnamon study. So I think it might have been the ivory study that you were asking when you were talking about.
The ivory study. It was performed in all of the infants. So all of the patients. So it had to be a recent, at the time of enrollment in the study. So whether it was an infant or an older child, it wasn't a historical data. It was the data at the time of enrollment into the study.
We've just got how long can an EHF be given to babies without causing any harm?
I'm happy to answer that. I don't think there's any harm. Using the hypoallergenic formula, I guess, you use it as long as you need this as a source of nutrition. And at the time when you start introducing sufficient amount of complementary foods, that it stops being a major source of nutrition. So you don't need to give them formula. So usually, like in my experience, and Nick, feel free to jump in. It's around. We like to have a formula in an infant with a cow's milk protein allergy until 18 months. But this is my practice in the US. I don't know how you guys approach that in the UK. But it feels like, having a formula as opposed to like a milk sort of beverage, alternative kind of beverages is a safety net because it has good amount of calories and calcium, vitamin D, other nutrients that those infants, are missing out by avoidance of dairy. But I have to say that, I just want to say that I have patients with eosinophilic esophagitis who are being, kept on amino acid formula, so even more sort of hypoallergenic formula for years until they were teenagers because they loved the taste of it and sort of used it as a beverage, and they were absolutely fine. So I don't think there's any time limit.
Yeah, we're fairly similar, really. So, certainly up to a year-old, we would go for a sort of hypoallergenic formula in cow's milk protein allergy. After a year-old, obviously, it's a little bit depending on what the patient want and what other formula milks they may, or other milks they might be able to tolerate, and how much milk is still part of the diet. So, if it's a large component, then absolutely we carry on. If it's dropped down dramatically, we may, depending on if the child tolerated it, go on to things like fortified soya formulas or oat milk. But certainly, we would carry on up till 2 years old easily if required with these hypoallergenic formulas. And like Anna says, depending on the condition, if they've got eosinophilic esophagitis, you use it for a much longer period. So I don't think it's a real definitive cut-off, but I suppose overall, in a cow's milk protein allergy, you wouldn't normally carry on beyond 2 years. So I think your sort of cut-off around 18 months sounds about right.
And I think thank you. I think we've got time for one last question. It's a nice, simple one. How do you prepare formulas, HMO formulas? I think they mean if, do you have to prepare it any differently than normal?
Yeah, no, I suppose this is the nice thing about a sort of prebiotic type component in the milk, is that it doesn't have those problems with heat making it ineffective. So obviously formulas that contain probiotics, which are live organisms, need to be prepared in a very specific way. And we know that sometimes this can be complex, although it sounds simple, it can be quite complex, whereas a prebiotic type formula, such as an HMO, doesn't need any of sort of a specific way of preparing it. You prepare it like any other formula.
That's right, and I think it's so easy, right? It's really easy, and I can only hope that with the sort of the progress within the industry, there will be just more effort to enrich those hypoallergenic formulas in more ingredients that are present in the breast milk, because if anybody needs them are the kids that have allergies, food allergies.
Okay, brilliant. Thank you very much for that, and thank you for your time today. And I think we've done a good kind of 10 minutes of Q&A now as well. So, and thank you very much for our speakers, and I hope everyone enjoyed the presentation today. If there's any questions that we've not answered, we can follow up and put that on the system afterwards. Okay. All right. Thank you.
Okay.
Bye.
Bye-bye. Thanks.
Do we go now as well?
Yeah, I guess so, right?
A bit confused.